Okay, well, we're right at 12:15, so we'll go ahead and get started. I wanted to welcome everyone to our quarterly educational event for Rocky Mountain Cancer Center. I'm Dr. Patrick Richard. I'm one of the radiation oncologists at RMCC Boulder, and I'll be your moderator for today's event. We'll be talking with four of my partners about managing the side effects of your patients while on active cancer treatment, and we hope that everyone finds this event educational and rewarding. I wanted to just introduce our panelists today. We first have Dr. Ioana Hinshaw, who's our medical oncologist practicing in Denver, Midtown, and Lone Tree, Skyridge locations. Dr. J.T. Link, who's a medical oncologist down in Colorado Springs. Dr. Katrina Oyague, who's one of our breast surgeons at our Louisville clinic. Dr. Meera Patel, radiation oncologist practicing with a home base in Aurora, but also covering Skyridge and Littleton, and Dr. Douglas Reznick, one of our medical oncologists in Aurora, Centennial, Swedish, and Littleton. So we truly do have a multidisciplinary panel today to address hopefully all aspects of active cancer treatment side effects. As always, a few housekeeping rules. Our attendees will be muted throughout the presentation. However, we certainly want you to be engaged by entering any questions or comments in the chat feature. We'll be monitoring those throughout the presentation and then addressing them for all of our panelists. Also, if you have any future topics that you want covered, the chat is a nice feature to add those as well, and we'll keep that in mind as we plan future events. Again, for those of you who carry COPIC risk insurance, your attendance will be directly reported to COPIC so that you earn that valuable ERS point. Again, thank you for taking time to join us today. The topics of discussion, again, will be the acute side effects in regards to chemo, immunotherapy, targeted treatments, radiation, and breast surgery. Our first topic is going to go to you, Dr. Link. I'd like you to address the common side effects that you experience with your patients undergoing cytotoxic chemotherapy.
So cytotoxic chemotherapy is probably one of the things that leads to the most amount of side effects. And as oncologists, we usually try to get out in front of this to the best of our abilities, but things do come up. And we know that because patients have such close ties to their primary care providers, sometimes they will reach out to you before they reach out to us. But some of the common things that people can experience are nausea, dehydration, and constipation. And I mention these three together because they often do come together. So it's very common for people when after they receive their first bit of chemotherapy to have some nausea, to stop drinking, and then become constipated. So whenever I hear about one of these three symptoms that a patient is having, we usually try to look into all three to find if one of these or all of them is a problem. And making sure that people are taking in several liters of fluid a day, making sure that their stool is appropriately soft, using sort of the common things that you're used to taking care of are all very helpful, but we try to be as gentle as possible. For nausea agents, we usually try to prescribe most patients 2 nausea medications, sort of one to sort of go-to medication, and Zofran is a very common one. And then we try to have a breakthrough agent for patients, and then something either to help them sleep or just to break through for nausea, and hopefully that will take care of things. As people sort of proceed through chemotherapy, poor appetite can often become an issue, and probably even more importantly, fatigue. And we really try to have people work on keeping their strength up through their chemotherapy. We want them to keep exercising, and that's probably one of the best things that we can do to prevent fatigue. Headache is another common thing that comes up, and headache is often also tied to dehydration. So we really try to make sure that we're doing a good job controlling the nausea to sort of help with that. And if you find that someone really you feel like is losing multiple pounds and really not doing well, make sure that they're in good contact with their oncologist so we can get them in to do IV therapies, either to address dehydration with IV fluids, or sometimes some of the oral nausea medications may not be strong enough. We may have to move to more IV therapies. But in addition to the common things that we run into with cytotoxic chemotherapies, there are also things that are more alarming to us. So people can become neutropenic 7 to 10 days after a chemotherapy, sometimes even despite having received growth factors. So when there are fevers or other signs of infections, particularly when they're a week to 10 days off of chemotherapy, we worry about the possibility of neutropenic fever. And for that, we definitely encourage patients to go to the hospital. So that's something to be aware of, and a reason for, if they contact you, to be in good contact with your oncologist that's working with your patient as well. It's uncommon, but because cytotoxic chemotherapy can lower any of your blood counts, sometimes patients will become significantly anemic. We're usually pretty good at watching for that. But we do have to transfuse patients sometimes. So if they get very tired, that's another thing to look for. And occasionally, chemotherapy can be severe enough to lead to bleeding by lowering the platelet count. So that's just another thing to watch out for. So from a primary care perspective, sometimes patients will have such a good relationship to you that they may come to you before they come to their oncologist. And it's just really helpful if you can help them through the simpler things and then send them back in our direction if you feel like there's anything more worrisome that's coming up.
Excellent. Thank you, Dr. Link. And yeah, I think one of the major advances in oncology has been the management of these acute side effects and being prophylactic as opposed to reactive. So definitely appreciate your discussion and work on that. I'd like to switch gears a little bit to some of the immunotherapy side effects. As we all know, the indications and use of immunotherapy has really expanded over the past decade. And so it's actually quite common that we're recommending this for patients with certain types of cancer. So I'd like to go to you, Dr. Hinshaw, in terms of one thing that often comes up is there's an indication to start a steroid while a patient's on immunotherapy. So my question is that something that is cautionary to do?
Yes, thank you. I would like to start by saying that immunotherapy has modernized the way we practice medicine. And it was first introduced in 2014 as a treatment for melanoma, a very chemo-resistant disease. And since then, the indications have expanded dramatically. And now almost all metastatic cancers have an indication for immunotherapy, either by itself or in combination with chemotherapy. Immunotherapy is also used as adjuvant therapy, and more recently as neoadjuvant chemotherapy, for example, for triple-negative breast cancer. So the point I'm trying to make here is that we use immunotherapy in everyday practice more and more. And as we use immunotherapy, we encounter more and more side effects, and we have learned how to manage these. From a simplistic point of view, what immunotherapy does, it activates the patient's immune system, the T cells, to fight off the cancer. And as the immune therapy is overly activated, it can actually induce some side effects, which we can think of as autoimmune-induced disorders. Immunotherapy can affect any part of your body, starting from the top to the bottom. So it can affect the skin, the gut, the liver, the kidneys. And I'm going to talk about the most common side effects encountered in practice. Skin toxicity is quite common. 40% of patients have pruritus in the absence of any kind of skin lesion. About 20 to 30% of patients will have a macular or macular rash. It's very uncommon to have dramatic skin reactions such as Stevens-Johnson. So I would say the most common is a macular rash affecting the upper torso, the legs, and the arms. Initially, this can be treated with topical agents. And of course, the primary care physicians are welcome to start this treatment. Patients are managed with Benadryl, Atarax for itching, and some topical steroids. Occasionally, when the reaction is dramatic and it affects more than 50% of the skin, we have to put the treatment on hold and start patients on high-dose steroids, about 1 milligram per kilogram, until the symptoms completely resolve. And then we start a slow taper over 6 weeks. Often we can restart immune therapy at that point, and occasionally patients do not recur. Another common toxicity is diarrhea. So colitis, autoimmune colitis, patients present with loose stools. Again, it can be mild and treated with just Imodium and Lomotil on a PRN basis, or it can be dramatic with more than 6 stools a day. Patients come to the office dehydrated, or they need to be admitted to the hospital for hydration and electrolyte replenishment. Again, treatment has to be put on hold if the toxicity is grade 3 or above, and we treat patients with steroids. We have patients in our practice who have bouts of diarrhea off and on, and they still are able to continue with immune therapy on an intermittent basis, and they still derive benefit. Other toxicities, again, common is thyroid-induced, thyroid problems, most commonly hypothyroidism, which is actually very easy to treat with Synthroid replacement therapy. More rarely, we can see hyperthyroidism. And honestly, if that would happen to one of my patients, I would recommend that they see the endocrinologist for management. Other side effects, renal toxicity, nephritis, hepatitis. And again, there's very strict guidelines how to deal with all the side effects. For example, I had patients with hepatitis. If the liver functions are 5 times upper limit of normal, we just hold the drug temporarily until the liver enzymes improve. On the other hand, if the liver toxicity is more severe and the LFTs are 10 times upper limit of normal, we have to treat with steroids. Again, 6 weeks taper. Other side effects that are more rare, pituitary dysfunction and adrenal insufficiency. I would like to point out the fact that, interestingly, some of these immune disorders can be delayed. So we have seen situations where the patient has long ago completed the immune therapy, and 6 months later presents with symptoms of feeling terrible, having nausea, vomiting, failure to thrive. And after a long workup, it's finally determined that the patient has drug-induced adrenal insufficiency, which can be very easily corrected with steroid replacement therapy. I'm not sure if I missed anything. Oh, the other thing is the incidence of these toxicities is higher with the length of time the patient is on treatment. And also, we expect more toxicity when we combine 2 immunotherapy drugs, or if we combine an immune therapy drug with a TKI. I have found some literature stating that the toxicities are higher in the younger patients who have a more active immune system. There's also some research to try to determine whether the emergence of these adverse effects are associated with response to therapy.
That's an excellent overview of the immunotherapy toxicities, and we know how much it has certainly helped us improve the cure and control, but often realistic to keep in mind how it can, people tolerate it very well, but there are certainly side effects that we have to manage. So we want to switch gears to Dr. Reznick. Another more recent advance in our ability to treat and control cancer has been, being able to characterize certain tumors in terms of actionable or targetable mutations. And so this has led to the development and utilization of targeted therapies for a growing number of malignancies. I'd love for you to address, Dr. Reznick, some of these new therapies, and particularly some of the unique side effects that our primary care colleagues should know about patients undergoing them. You're on mute, Dr. Reznick.
There we go. How's that? Perfect. Right. So a little bit of a historical perspective. So when you think about targeted therapies, they've actually been around for several decades, tamoxifen was really the first. So how you characterize a targeted therapy is it's changed over the years, and then we really characterize them according to their spectrum and their mechanism of action. But a hormone therapy, in a sense, is a targeted therapy. So when I talk to patients about specific targeted therapies, I often give them analogies of like fighting a war. Chemotherapy, it's kind of like carpet bombing. It kills the good, the bad, and the ugly, and hopefully all the bad and the ugly stay down and the good rise up and all's well. Where targeted therapy is more like smart bombs. We understand the mechanism of action very clearly, and there's many different types of targeted therapies, which I like to think of as a third category of systemic therapy that we're using in our cancer treatments today. Hormonal therapies are one, and we've got others like tyrosine kinase inhibitors, which specifically, as Dr. Richard was mentioning, they target various gene alterations. We've got other targeted therapies that target proteins. We've got monoclonal antibodies, and I'm sure many of you have seen these drugs or have been familiarized in many of our notes with many of these drugs, and they're quite abundant. We've got dozens of different types of targeted therapies, and we can actually spend a whole weekend talking about all of these targeted therapies. They all work differently, and many of them have very different side effects. Specific to the genetics, there's 5 tumor types today. Lung cancer really at the forefront, prostate cancer, breast cancer, melanoma, colorectal, where we are discovering more and more genetic alterations that are associated with these patients' tumors. And it's really important to get a full understanding of the genetic underpinnings of the patient's tumor so we can best treat them with the most appropriate systemic therapy. And so under targeted therapy, if we think about gene therapy, specific to those patients who may have an underlying gene alteration, whether it's a gene mutation, a gene insertion, a gene rearrangement, we have drugs that are specific for that patient's cancer. And you mentioned the word driver. So we talk about driver mutations or mutations that have actionable mutations. So if a mutation is actually actionable, we can actually use a drug that targets that's driving that patient's cancer and pretty much kind of turn it off. So when a genetic mutation occurs, let's say in someone's lung cancer, they have an EGFR receptor mutation, the downstream effects of that, including cellular proliferation, signal transduction, et cetera, continues to allow that cancer to drive itself. Programmed cell death eventually occurs, but the cycle doesn't stop. And these drugs actually interfere with that receptor mutation, thereby getting that cancer to remain inactive, into remission. And the advantage of the targeted therapies is most of them are oral, not all. So they're much more convenient to administer. The side effects in general are much more mild. When you look at all toxicities, compared to chemotherapy, for example, they're mild to moderate. And the majority of toxicities we would characterize as a grade 1 or a grade 2. So oftentimes, if patients are experiencing side effects, they may not need to interrupt treatment, and they may not need to even dose reduce therapy. But for many of these drugs, that option is available. So when you think about many drugs for lung cancer, for example, there's drugs that have class-specific side effects, and then there's drug-specific side effects. And so there are some unique side effects to certain drugs. But when you look at many of these tyrosine kinase inhibitors as a whole and as a class, common side effects can be fatigue. It's generally not as impactful as with chemotherapy or perhaps as immunotherapy can be. The gastrointestinal side effects, we typically don't see much in the way of nausea and vomiting. It could be more of diarrhea. We often see more cutaneous side effects, rashes, pruritus, nail changes, sometimes some mucositis. And don't forget about laboratory abnormalities, even though they're not as common with targeted therapies as they can be with the chemo and immunotherapy drugs. They may occur, but again, much, much, much less common. So it's important to at least acknowledge patient CBCs, metabolic panels, et cetera. Some of the rare side effects that we can see include some cardiac manifestations, whether it's cardiac, contractility issues or conduction problems. For many of them, we can see some lung injury side effects. So people often ask, well, can these side effects remain like some of the side effects people experience with chemotherapy? We can see some long-term toxicities if the drug is not managed in a timely manner. But for the most part, most of the side effects we encounter with the targeted therapies are usually reversible. And if they do start to experience a cardiopulmonary side effect, for example, I think if we get on top of it in a timely manner, it generally does not become a long-term problem. I think I'll stop there.
Excellent. No, very broad overview of where we've come with targeted treatments and how patients generally do. So we may circle back around to you at the end with some additional questions, but I do want to remind all of our attendees to please, again, shoot any questions or comments you have through the chat function, and we'll make sure to come back around to cover those at the very end. So we want to switch gears now to two of our local therapies for various cancers, being radiation and surgery. We'll start off with you, Dr. Patel. In terms of one of the most common reactions, probably what radiation is most known for, which is radiation dermatitis. Kind of when do you expect to see that, and how would be your approach to managing that?
Great, thank you. Yes, so a little bit of shift in gears now from a broad overview to something more localized. When I was asked to speak about this, I spoke with Dr. Richard, and I wanted to think of topics that are quite pertinent to radiation. So radiation dermatitis is probably one of the most common side effects of radiation therapy. Please do not go out and Google radiation skin reaction, because the pictures are horrific. And I promise you, we don't tend to see those in clinic. And it affects approximately 95% of patients, though. It's obviously a different intensity depending upon the type of cancer that we're treating. Most commonly, we see the radiation skin reactions with breast cancer, head and neck cancers, sarcomas, anal canal, rectal canal cancers, and then obviously skin cancer, where we're trying to get a high skin dose. What we see with regards to the skin changes is really dependent upon the radiation dose and the time frame, and they can include erythema, edema, hyperpigmentation, loss of hair within the treatment field, and then when it gets more severe, we see dry desquamation, moist desquamation. They tend to be cumulative side effects, so especially on patients who are having a few weeks of treatment, the first few weeks tend to go by pretty smoothly, and then near the end, as the radiation dose builds up, we see these cumulative changes. It usually starts with the erythema, and then the hyperpigmentation, and then it moves on to the desquamation. There's lots of different grading scales that you can use, but really the diagnosis of acute radiation dermatitis is purely a clinical one. It's based upon the findings and the changes that I've mentioned. With regards to the different radiation therapy techniques, either how we're delivering it with intensity modulated radiation therapy or arc therapy, or the different approaches, for example, stereotactic, you can notice a change in the timeline. So some patients may actually develop a skin reaction, specifically if I'm talking with regards to breast cancer, when we're doing partial breast radiation, they may actually develop a skin reaction after the radiation is complete, and that's very common. We talk to all of our patients about that. Managing it, before our patients get started on treatment, we go through teaching. We have excellent nurses, and our nurse here makes sure that she talks to every single patient before they get started. There's a lot of differences out there with regards to should we prophylactically ask patients to do something on their skin or wait until we see an actual skin reaction. In our clinic here, we go through general skincare guidelines, meaning keeping it clean, keeping it dry, using some moisturizing lotions, but we don't prescribe anything until we actually start seeing true radiation dermatitis. They have done the studies, and trying to prophylactically doesn't tend to significantly alter outcome. So with grade 1 radiation dermatitis, where it's just a little bit of erythema, maybe some hyperpigmentation. We talk about moisturizing, keeping it dry, and then obviously keeping it out of the sun. When it progresses to grade 2 to grade 3 as the treatments progress, or if we see moist desquamation at that time, we're always making sure that there's no risk of a bacterial superinfection. If there is desquamation, we tend to prescribe Silvadene, which is quite effective in helping with that desquamative reaction if it is contraindicated in someone who does have a sulfa allergy. Lidocaine in the sensitive areas, especially when we're treating rectal, anal, vaginal regions. We also have different gel sheets that they're made for radiation. They're called Radiacare Gel Sheets that helps just provide and promote an environment for healing. We're seeing these patients weekly while on treatment. Our radiation therapists are seeing them daily. So we can make those assessments whether or not we need to continue. The skin reaction usually lasts about 2 weeks after the radiation is done. And at that point, as Dr. Link had said, because they have such a close close relationship with their primary care, a lot of phone calls are probably being made to your clinics to talk about that. But it will dramatically start to improve about 2 weeks after the radiation is done. And then over time, the hyperpigmentation resolves and the skin tends to get back closer to normal.
Excellent. And switching gears to another organ that we sometimes will see toxicity to is the radiation-induced pneumonitis. I think this is really important for our primary care colleagues to know because the onset's a little bit later than during treatment. So could you touch on the diagnosis and management of pneumonitis?
Yes, absolutely. So for radiation-induced lung injury, there's two separate entities. There's one which is radiation pneumonitis and then radiation fibrosis. So radiation pneumonitis is known as what we call this acute exudative phase. There's excess surfactant production, just makes everything really sticky. This happens about 4 to 12 weeks after the radiation. So it doesn't tend to happen when patients are actually on radiation. So the timeline for that is about 4 to 12 weeks after the radiation exposure. The late effect of radiation-induced lung injury is radiation fibrosis, and that's where there's an increase in the number of myofibroblasts and narrowing of the alveolar spaces. So it's a different pathophysiologic entity from the pneumonitis. And that happens 6 months after. So it's a little bit of a different time frame. So subacute radiation pneumonitis, 4 to 12 weeks out. Fibrosis, 6 to 12 months out. Symptoms of both are quite similar: dyspnea, cough, chest pain, fever, malaise. And then the physical exam, it can be very frustrating because it can be anywhere from crackles, pleural rub, dullness to percussion to nothing at all. And so the diagnosis of radiation pneumonitis really is based upon a correlation of the onset of the signs and symptoms with the timing of the radiation and physical exam if it is helpful, but then also we can take a look at the radiographic changes. So before, historically, it was recommended that we do a chest x-ray. You may see some perivascular haziness. Now what the recommendation is if people are coming in with these symptoms and they're fitting that time frame, a CT scan is better. It'll most likely, if it is there, it'll show patchy alveolar ground glass or opacification. The thing with radiation pneumonitis is it tends to be, you can see it within that radiation field. So when I am seeing patients that potentially could have developed this, what I will ask our dosimetrist to do is take the CT scan that we've done for a diagnosis and fuse it to their treatment plan. And what you see is sometimes known as what we call that straight line effect, because nothing in the human body really is a straight line. But if you see that radiation pneumonitis following your radiation field or following your radiation beam, that's also very indicative that that's related to the radiation. Treatment for, if it's very, so the optimal treatment is a little bit, it's not really well known. For patients who are asymptomatic, what we tend to do is just do supportive care. If they're having a cough, help with the cough. But I don't tend to initiate steroid treatment unless they are actually having moderate to severe symptoms and it's affecting their quality of life. So what the treatment for that is prednisone. It's approximately 60 milligrams per day. I tend to keep patients on that for 2 weeks. You can do it anywhere from 2 to 4 weeks, and then a gradual taper. Gradual taper, I tend to do that over 8 to 12 weeks. So that's why it's not really ideal to just jump to go ahead and put people on prednisone, but the treatment for either the pneumonitis or the fibrosis is to start with prednisone.
Excellent, thank you. And I always encourage PCPs to please contact us if your patients are having those symptoms, you know, in the aftermath of radiation, because we can do that analysis, like Dr. Patel said, to really see whether it's in the field of radiation and can help you manage from there. So we want to switch gears to our last panelist. She's been waiting eagerly to talk about her passion in life, which is breast surgery. Dr. Katrina Oyague, I'd like to have you discuss really the perioperative side effects in some of the breast surgeries you do to help our PCP colleagues.
Yes, thank you. I'm mainly going to focus on not really the acute symptoms because of the surgeries that we do. And again, I'll be focusing on lumpectomy, mastectomy, axillary staging with sentinel lymph node biopsy or axillary dissection, and then chemotherapy port placement is another thing that we as breast surgeons commonly do. But the active or the immediate post-op period, I do believe those symptoms should be managed by us, the surgeons. But as we get further out, so out of that 90-day window, then I do think that there's a big role for the PCPs. And then a lot of these symptoms can persist, meaning that these are lifelong things. And so these are also things that you should have in mind if you see patients years after treatment, because there's interventions that can really improve people's quality of life. And so within this scheme of symptoms that I see after breast surgery, there are both physical symptoms and psychological symptoms. And the physical symptoms are kind of all interrelated and on a spectrum. And so this is pain, scar, and then lymphedema. And obviously, any surgery causes scar, and then breast surgery in particular really can form a lot of scar because sometimes adding on the radiation exacerbates that, and then doing axillary surgery at a joint in the axilla can really cause a lot of change in range of motion and limitation for people, as well as some of the more reconstructive procedures that we do, replacing implants and moving muscles. So all of that really does have the ability to cause pain and scar. Lymphedema in particular is something that I think we are obviously more educated about it now, and we try to educate our patients ahead of time. And I think education and understanding that it exists and that it is a unfortunate, unavoidable side effect of what we do with axillary staging is really important, because if patients are empowered and know about it, then they just do better over time. And that these are lifelong risks. The risk of lymphedema doesn't ever really go away. And honestly, scar from a surgery doesn't ever really go away. And so these are things that people should be doing over the long term. I stress scar massage. And so it's not anything that there's really a technical way of doing it. It's just touching and feeling the area and then stretching and trying to work through some of that scar. And patients can do this themselves. And then this can also be done by a physical therapist. Same with lymphedema, because again, when we do that surgery, we remove lymph nodes and simply just working in the space with the lymphatic channels, we disrupt the flow of that lymph, and fluid can build up. And this is fluid that obviously the textbook answer, again, if you Google it, you'll get horrific pictures of giant blown up arms, but we try to decrease the amount of axillary surgery that we do nowadays. We actually have procedures where we're trying to, reroute the flow of lymphatics to try to decrease these at the time of surgery. And so ideally, you're not seeing the big blown up scar, but like I said at the beginning, these are on a spectrum. And so patients are still going to get some symptoms. And usually what that is heaviness or tightness. They can feel like they have a band that's pulling underneath their arm. Their breast can feel heavy. Their chest wall can be feeling like it's swollen and heavy. What they can end up doing is their own massage of that area, both at the extremity, the breast, the chest wall, and they can do them this themselves, or a lot of patients can't do it themselves. They have neuropathy of their hands or something from their other treatment. And so you kind of have a lymphedema, a specialized physical therapist help with that, or we have pumps and compression garments. I don't think the garments work very well, but I do think the compression pumps really do. And if they're started within the first year, patients love these. They're pneumatic pumps that insurance covers, and they wear them at night, like when they're watching TV, and then it treats the symptoms, and people do great with them. I think the other important thing to kind of highlight are psychological symptoms. And after, I think just the cancer diagnosis with the lack of control associated with the diagnosis, and then breast surgery in particular is very body dysforming, and we try to mitigate that, but obviously some of it certainly exists. Mastectomies and amputation, and then lumpectomy changes the size and shape of the breast. And so encouraging patients to touch, look, and feel really do help. Patients get over some of that body image, and a lot of patients don't want to, so you have to push them a little bit to do it. And then ask how they're doing with things emotionally, because there are sexual side effects, and these can really affect people's relationships. And you may not have the answer of how to fix it, but a lot of patients don't need an answer. They just need reassurance that it's normal to go through these feelings: anxiety, depression, body image, sexual changes, all of those things. If you just reassure them, a lot of times that's enough to tell patients that what they're going through is reasonable, and that often it's temporary. And then certainly reach out to us. We have resources and can help patients with that. So I don't know if there's more that you wanted me to touch on, Dr. Richard, but I think should be coming to a close.
Yes, that is an excellent overview of the common things we see in the aftermath of the surgeries you conduct. And I want to congratulate the panelists, because in less than 45 minutes, you've covered a high yield overview of all the major things that we encounter during any of the cancer treatments we deliver. And have done such a good job. We don't have any questions at the moment, but I happen to have a question directed to both Dr. Hinshaw and Dr. Reznick. Maybe Dr. Hinshaw first. You mentioned that depending on the severity of side effects, there may need to be a brief pause on the use of immunotherapy, or in Dr. Reznick, the targeted treatment. My question would be how long of a break, and some of the general parameters you would use to either restart that treatment or really just scrap it and move on to that next line of systemic therapy.
The literature says to hold the immune therapy until the grade of the severity grade goes to a grade 1. I mean, in practice, what I do is I ask the patient if they feel close to baseline, and if their symptoms have resolved and they feel their normal self, I usually resume at that point.
I think when it comes to the targeted therapies, there's no hard date or time frame. I think it really comes down to the grade, so grade 1, oftentimes we don't need to hold treatment or dose reduce. We can continue treating uninterrupted. I think grade 2 and above is where we may be holding and subsequently dose reducing if reintroducing the drug is feasible. And again, it also depends on the toxicity. When you look at many of the clinical trials, when it came to some of the toxicities, some of them use 2 weeks, some of them use 3 weeks, specifically in regards to the cytopenias, for example. And keep in mind, when a lot of these drugs were studied, no growth factor support was permitted on these studies. So patients were often taken off study and removed from drug treatment for a cytopenia, for example, that didn't resolve itself within 2 to 3 weeks. Some of the rare cardiac stuff, I think it depends on, again, on the grade. Sometimes they'll be dose interrupted, and then if they have, let's say, they develop CHF as a result, they'll be started on appropriate therapy to improve LV's drug at a lower dose if their ejection fraction improves well above 50%, for example. I think when it comes to pneumonitis, which again, I think Dr. Patel gave a very nice overview of pneumonitis, and I think we can all speak to pneumonitis because all these categories of drugs can cause pneumonitis. Interestingly, the mechanism of action is different, but I think when it comes to therapeutic intervention to counteract the AE, it's often steroids for most of these patients, again, depending on the degree of that side effect. But again, with immunotherapy and targeted therapy is if they develop a grade 3, grade 4 pneumonitis, we probably will not reintroducing drug. So there's a lot of depends, you know, and I know people want to affirm definitive answer, but there's so many different mechanisms of action, different types of drugs. And so all of these things are taken into consideration when, you know, these decisions are made as far as how we treat, when do we intervene, and if and when we resume treatment.
Excellent, thank you. Dr. Oyague, you obviously and appropriately mentioned lymphedema as a potential consequence of the breast surgery. And I think despite the decreasing incidence of this with less aggressive axillary management, our patients always bring it up. And that's one of the most terrifying consequences. So you mentioned breast physical therapy. I'm wondering if you can expand upon that to help us understand, really, are you referring all your patients for this, a case-by-case basis, and when would you make that referral after surgery?
Yeah, I pretty much refer all my patients for focused physical therapy, and they can always refuse, but most people want it. And then sometimes it's one visit, and then sometimes people need it regularly. You know, a young, healthy person can do their own stretching and massaging, but older patients need help. And then depending on the severity of the symptoms, that's when you start getting into other treatment strategies like compression garments, which nobody really likes, and then the pumps, like I was highlighting, because I think there's a big role for those, because patients don't have to do it themselves. It's a treatment at the end of the day for most people when they're watching TV, and then really can help with those side effects. And it's covered by insurance, and you can, a lot of these patients meet their deductible right out of the gate. And so then it's something that just gets to show up, right? I think other treatments that you can consider that patients like, acupuncture is another one. I think a lot of it's just education, because some of these symptoms, people don't realize they have lymphedema. And this is where I was getting at, that sometimes I see patients 5 years down the road and they have symptoms, they just never knew it. They didn't know that they had lost range of motion. They didn't know that this heaviness or this achiness in their arm or their shoulder was related to that. Or sometimes when we're treating people in the rare event of a recurrence and we're trying to get something to heal, if you don't have control over that lymphatic flow, you can't get the wound to heal. So it really does affect patients down the road. And so I think the most important thing is be on the lookout for it, be aggressive with managing it, and educate.
Excellent, thank you. So we are almost at the end of our presentation today. So I again wanted to
sorry to interrupt.
Oh, yes.
Dr. Richard, there were a couple of questions in the chat box.
I cannot see those. Okay, here we go. Sorry. Yeah, let's back up here. Thank you, Dr. Patel. So this question, really, I think Dr. Link had to drop off, but I know Dr. Hinshaw and Dr. Reznick will be able to answer these. When do you typically use growth factors if a drug has a higher risk of causing neutropenia? In terms of how often, prophylaxis, or weight, what would be your approach to that?
Yeah, so I think the growth factor support has had a very strong footprint in the chemotherapy world for a long time now. Depending on how toxic the regimen is, depending, you can actually predict how myelosuppressive the chemotherapy regimen may be on your bone marrow. You actually may use it preemptively or prophylactically up front, because you know that that patient is going to become neutropenic and it will delay treatment and affect outcome. So sometimes you'll use it as a primary prophylaxis. Other times you'll implement it secondarily after they've experienced a febrile neutropenic episode, for example. As far as the targeted therapies, a lot of these drugs are oral, and so they're daily. And so there's really no role for these drugs in the targeted world. With some of them, and most of the oral drugs are, the tyrosine kinase inhibitors. Some of the monoclonal antibodies we use, for example, which are intravenous, those are given on a scheduled basis. They may be every 2, 3, or 4 weeks. There may be situations where you would use them under those circumstances. But with a lot of the oral targeted therapies we speak of that specifically target a lot of the genetic alterations that we encounter in our patients, the growth factors typically don't have much of a role. I'll let Dr. Hinshaw
you.
speak to immunotherapy. Sure.
Yes, all I want to add is that immunotherapy does not cause immunosuppression. That's why we love to use immunotherapy, because it's less toxic overall. And again, there's really no role to use growth factors, in this situation.
Thank you. In the final minute, Dr. Oyague, have you ever seen benefit from osteopathic techniques to reduce the incidence and severity of lymphedema after mastectomy or lumpectomy?
I'm not familiar with those myself, but I don't see any downside to any of that. I think stretch, massage, working any sort of lymphatic flow techniques make a big difference. And so I think using those and teaching your patients those strategies are great. These are things that patients have to do now until forever. And so empowering them with tools to treat themselves is huge. And if you have those skills, that's fantastic.
Excellent. All right. Thank you, Dr. Patel. Glad we caught those questions. So that'll wrap up the session for today. Again, I want to thank our panelists for spending time discussing these important topics. I want to thank our attendees for being with us today. And again, we welcome any and all feedback. When you get the post-session survey, please provide honest and useful feedback for us as we continue this quarterly session. So we'll see you again in July. Thank you all. Have a great day.